Hi everybody, and thank you for joining me in this short video presentation regarding the ECG exercise number 9. I hope you will enjoy it and join me in my future video presentations. In the ECG on admission, we see atrial fibrillation with rapid ventricular response, and in the next slide, we will see the ECG after cardioversion. This patient had a short PR interval, as we see here, in normal sinus rhythm with a small QRS complex. This could be due to supernormal AV conduction, which is assumed to be the underlying cause of LGL syndrome. The patient reported having recurrent tachycardia since childhood, which became less frequent over time until atrial fibrillation was diagnosed. Careful inspection of the ECG reveals a missing septal Q in left lateral leads, which represents the initial activation of the interventricular septum by the left bundle branch. After adenosine administration, there was no widening of the QRS complex. The initial part of the adenosine testing showed a sinus bradycardia with already described QRS complex. After the fourth complex, however, the patient developed an AV junctional escape rhythm where the septal Q wave in the left lateral leads reappeared. Based on this, we made a diagnosis of an accessory pathway, and the EPS study localized it to the parahiscine region. The explanation for this is the following. During normal sinus rhythm, there is a parallel activation of the AV node and the accessory pathway, resulting in minimal pre-excitation and loss of septal Q wave in the left lateral leads. During AV junctional rhythm, ventricular activation propagates antegrately over the His-Purkinje system with activation of the interventricular septum in a left to right direction via the left bundle branch, which produces the septal Q wave. At the end, I hope you enjoyed this short video presentation, and I would like to invite you to joining me here in my future video presentations.